Move aside so people can see the CME.
This is for today.
Yeah, I also put it in the chat.
Okay.
Okay. Thank you. It's great to see you all today. This is my first time introducing Andrea as Dr. Maxwell.
Yay.
First, PhD in neuroscience. She also has a bachelor in neuroscience with distinction. And she has so many, it's such a long list of awards and travel awards and poster awards that I did not write it down. The research that she's going to present to us today was funded by the NIH by an F30 on gender differences, on the effects of stress, social support on alcohol use. And I have to say what's most remarkable about her from my perspective as her supervisor is that this was truly her vision. She came to me 4 years ago, 5 years ago?
5 years ago.
5 years ago and said, okay, this is what I want to do during my PhD as my research, and presented me a PowerPoint with 10 slides. And you're going to see about half of that now. So we agreed that about half of it would be doable. So without further ado, I'll give the word to Andy.
Thank you all for having me. It's good to see everybody. I'm like Anna said, I'm actually just defended, but we'll be starting clinical rotations on Monday and happy to be starting in psychiatry. So hopefully I will see some friendly faces on Monday morning. Okay, so I'm going to present to you some of my doctoral research on sex-gender differences and the integrated role of neurobiological, psychological, and social factors on alcohol misuse. So I know I don't have to convince this crowd that alcohol use disorder in the United States is a challenge. In the most recent NSDA, so the National Survey on Drug Use and Health from 2023, 10% of folks 12 and older endorsed past AUD, and this is actually an underestimate because the NSDA actually excludes everybody who's incarcerated, experiencing homelessness, or on active military deployment. Together, this incurs about $250 billion in social and healthcare costs every year, and in Minnesota in 2019, that accrued $8 billion. But despite these enormous costs, less than 10% of folks seek treatment. This is concerning because alcohol misuse is a leading cause of death in the United States. 488 deaths a day can be attributed to consequences of either excessive drinking or alcohol-related conditions. And in younger adults, so around 20 to 50, this explains one in 5 deaths. So a significant contributor to premature mortality in the United States. Additionally, there has historically been a gender gap in alcohol use, and you can see this in this longitudinal figure here. So on the left are on the baby boomers, men who are represented in blue, relative to women who are represented in green, tended to endorse higher levels of drinking, but that gap has decreased over the years. And we can see that now men and women tend to report alcohol use at about the same rate. And in fact, in 2023 was one of the first times that younger women, so around 18 to 25 years old, actually reported binge drinking more frequently than men. There are also sex gender differences in alcohol-related problems. So there's been an increase in alcohol-attributed deaths, as I showed you, but this is particularly true in women. So there's been a 27% increase in men relative to around a 35% increase in women, respectively, in alcohol-attributed deaths between 2016 and 2021. But despite these increasing consequences, there's actually been a decline in AUD treatments overall, and women are less likely to seek and receive alcohol treatment services. One of the challenges in treating alcohol use disorder, as I'm sure most of you are aware, is that there's an incredible level of heterogeneity in explaining alcohol misuse. So there are a plethora of neurobiological factors that contribute to alcohol use, for example, dysregulated opioid or dopamine, neurotransmission in the basal ganglia, recruitment of CRF, norepinephrine or dynorphin in the amygdala, an extended amygdala, dysregulation of glutamatergic projections from the prefrontal cortex. But there are also psychological factors that contribute as well, including approach behavior, altered reward processing, increased negative emotionality, as well as altered executive function. In addition to these neurobiological and psychological factors, of course, there are social factors that contribute as well. For example, interpersonal support or lack thereof, community networks, as well as a lack of access to healthcare all contribute to alcohol misuse. And although growing work has examined the interaction of neurobiological and psychological factors when explaining alcohol misuse, actually varied work has examined the interaction of these factors and how they explain alcohol misuse. Additionally, there's the added layer of complexity in terms of sex and gender differences in alcohol misuse patterns. In preclinical models, we see that female rodents tend to exhibit heightened cortisol reactivity to stressors, as well as consume more alcohol relative to male counterparts when stressed. And this preclinical work is supported in clinical models where we see, in general, women with substance use disorders tend to report greater stress response as well as less stress tolerance and seem to be more likely to relapse to a stressful trigger. And this together has informed this model of sex differences in positive and negative reinforcement drinking, such that it posits that in general, women on average tend to drink as a form of negative reinforcement, so kind of drinking to cope or stress coping, whereas men on average tend to drink as a form of positive reinforcement, so really for that social reward. So in addition to this heterogeneity that I showed you between neurobiological factors, psychological and social factors, there's the added layer of sex gender differences in this model. And this was really what I was interested in examining in my doctoral work. So that brings us to my first chapter, sex gender differences and the psychosocial determinants underlying the onset and maintenance of AUD, and this was published in Frontiers in Neuroscience in 2022. So this was a follow-up study to a study done by a former postdoc, now assistant professor at UNC Wilmington, Eric Rawls, in 2021. Eric generated a data-driven model of social, neurobiological, cognitive, and emotional causes of alcohol use disorder symptoms. To do so, he used the Human Connectome Project, which is a publicly available data set of healthy young adults. The sample was 926, a little half of whom were female. And he used 100 variables that were available through the HCP, the Human Connectome Project, and conducted exploratory factor analysis, which produced 18 latent factors that probe brain, cognitive, emotional, and social factors. He then applied causal discovery analysis, which I'll explain in just a second, to generate this data-driven model of increased alcohol use disorder symptom severity. So very briefly, causal discovery analysis is basically a machine learning approach to infer causal structure from observational data. What that means is if, for example, you have this puddle of water, there are many different structures that could have caused this puddle of water. In this case, this would be our data. So you could have your classic ice cube structure that melted to cause this puddle, but if you all of you live in Minnesota and presumably are also here for the winter, so you'll know that there are many different ice sculptures that can melt to generate this puddle of water. So there's snowflake, more complex, and some award-winning structures all melt to generate this puddle. CDA then performs conditional independence tests to generate this causal model, so to estimate the structure that is causing this puddle. Importantly, the form of CDA that we use also accounts for unmeasured causes. What that means is if you have all these different structures that can melt, but you have a cute little family traipsing through your ice sculpture and causing the ice sculpture to melt in unmeasured ways, CDA can account for these unmeasured causes. So Eric generated a causal structure leading to AUD symptoms, and he had proposed this hierarchy of causal influence that began with these brain-derived factors in the top right, then led to these cognitive factors, these social factors that are shown in green, then led to these affect and psychiatric function factors in red, and then led to increased AUD symptom severity that you can see in black. Importantly, he didn't account for gender in this model. And I was particularly important, again, in these gender differences, but really in this role of social support that you see in green, having this causal influence on AUD symptom severity. So I conducted a narrative review of the existing literature that is now included in this paper, and I found that in general, familial social support seemed to be particularly important for adolescent girls relative to boys in predicting alcohol use, and that there were also gender differences in the effect of peer-derived social support, such that drinking peers seem to be greater risk factor in girls, whereas emotionally supportive peers seem to be more protective in girls relative to boys in protecting against alcohol misuse. Importantly, this role of social factors seem to have a larger effect on alcohol misuse in adult women and relative to men as well. So we see this continuity between the adult and the adult, between the adolescent and the adult literature. And together, that narrative review and Eric's analysis informed the current study aim, which was to examine sex gender differences in the causal model of AUD symptom severity. So I use the same exact data set that Eric used for the Human Connectome Project, sample of 926, a little over half of whom were women. They were mostly white and they were all young adults, around 28-ish so years of age, with an average income of around $45,000. And again, I applied causal discovery analysis separately in men and women to generate these causal structures. And what I found, so women are on the left, men are on the right, is I found this very striking continuity in the causal structure leading to increased AUD symptom severity down here in black between women and men, such that there's this flow from these cognitive factors in blue, so these social factors in green, negative affect factors in red, leading to increased AUD symptom severity. But the key difference that I want to show you is that in women only, there seemed to be this causal effect on social support, such that lower levels of social support caused increased levels of negative affect, internalizing conscientiousness, and increased AUD symptom severity. In contrast, you can see that in men, these low levels of social support did not seem to have this causal effect on AUD symptom severity in this sample. So these suggest that high social support led to lower negative emotionality and lower AUD severity in women only. And this implicates that social factors seem to be particularly important for women in conferring risk and resilience to alcohol misuse. However, when I was examining the literature, I found that the literature is extremely limited. For example, social support is a very complex factor. It was unclear which components of social support, if any, were specifically driving this effect. And of course, this did not address neurobiological mechanisms driving these sex or gender differences. So that led me to my second chapter, which was a systematic review of sex-gender differences and the multidimensional neurobiological mechanisms in addiction and their relevance to impulsivity, which was published in Current Addiction Reports of 2023. So the triadic model of addiction posits that alterations in three functional neurobehavioral domains are linked to higher levels of substance use in general, including alcohol use, and these domains are executive function, altered approach behavior, reward processing, and negative emotionality. Importantly, impulsivity, which is also implicated in substance use disorders as well as other psychiatric disorders, also maps onto this triadic model. This is one structure of impulsivity, and impulsivity maps onto this triadic model, such that these factors of sensation seeking and positive urgency map onto approach behavior, lack of premeditation and lack of perseverance onto executive function, and the negative urgency onto negative emotionality. Importantly, there are also sex-gender differences in the role of impulsivity in these triadic domains. So, for example, men tend to demonstrate greater risk-taking and self-reported sensation-seeking relative to women. As I mentioned before, women with substance use disorders are more likely to relapse with stress relative to men. And then there's some literature, although limited, to suggest that women with severe alcohol misuse may perform worse on some working memory tasks relative to men with severe alcohol misuse. Despite this evidence, there's actually very limited synthesis of these findings regarding differences in these neurobiological mechanisms, and together that informed the current study aim, which to examine the existing literature in human fMRI research regarding sex-gender differences across approach behavior, negative emotionality, and executive function. So I examined the extant literature looking at sex-gender differences in neuroimaging, and there were 34 papers from 2000 to 2023 that fit these criteria, and these are the descriptive kind of characteristics or results. You can see on the far left here that by far the most frequently reported substance of misuse to study was alcohol and nicotine, followed by cocaine. Very little of anything else, notably no opioids. And the most commonly studied neurobehavioral domain was the approach behavior, so that reward processing behavior. That was then followed by negative emotionality, and finally by executive functioning. And there were 10 papers that examined resting state. We can see that in general, in the kind of middle here, that men tended to be overrepresented in these samples, with 33 men relative to 24 women, but the most frequently reported sample size was just 10 men and 10 women, so very small sample sizes overall. I then examined which brain regions were the most frequently reported brain regions to evidence a sex-gender difference, and I will orient into this figure here. So on the x-axis, there are brain regions that reported any sex-gender differences in any of these 20 papers that examine approach behavior. In black are the number of papers that found a sex gender difference, and in white are the number of papers that did not find a sex gender difference. And we can see that the most frequently reported region to evidence a difference was the OFC VMPFC, such that in general, men tend to report greater reactivity of the OFC or VMPFC to these rewarding or approach-related cues relative to women. I did the same for negative emotionality, and we can see that again, the OFC VMPFC was the most frequently reported region to evidence a sex gender difference, such that women more so than men. So in contrast to what I just showed you, women evidence greater reactivity to these negative emotionality cues, or kind of more these aversive cues relative to men. There were only 3 papers that examine executive function, which precludes any conclusions, but all 3 of those papers use the same executive function task, so very little heterogeneity in that task. And there were 10 papers that examine resting state, so that's when people are just put in a scanner and just asked to kind of chill there, and instead of doing a specific task in the scanner. And there were no clear patterns there. So again, we found that the OFC VMPFC was the most frequently reported region, such that men more so than women had greater reactivity to rewarding cues, whereas women more so than men had greater reactivity to stress cues. And this is not surprising because the OFC has an integral role in the processing of subjective value of stimuli, as well as reward expectations, and is also implicated in impulse control. Their lesions to the OFC tend to result in dysregulated impulsivity. Importantly, there are also sex gender differences in the OFC in the general population, such that men, more so than women, again, have greater OFC responses to these appetitive cues, whereas women, more so than men, tend to have greater responses to these negative or threatening cues. So together, this paper found that the OFC VMPFC function may be a neurobiological mechanism that's associated with these sex gender differences in substance use populations. And importantly, these findings converge with that negative and positive reinforcement model that I showed you earlier, such that men more so than women respond to rewarding cues, whereas women more so than men respond to these negative emotionality cues. But importantly, this paper did not address the role of social function in the model, which I showed you in chapter 1 seems to have the sex gender specific effects on alcohol misuse. So that informed my third paper, which is sex gender differences in OFC reactivity underlying the associations between stress, social relationships, and problematic alcohol use, and it's currently in revision. Excuse me. So to recap, I showed you that in chapter 1, I demonstrated that there are sex gender differences in negative emotionality and social support on alcohol use. In chapter 2, I demonstrated that there are sex gender differences in the role of brain function in this interaction. But actually, very little work has looked at negative emotionality, social function, alcohol misuse, and sex gender differences in a single model. And no work that I'm aware has examined additionally the role of the brain function as a moderator in this interaction. So to inform the current study aimed, which was 1, to answer the question, is the effect of social function on alcohol use moderated by stress and sex gender? If so, which dimensions of social function are driving this effect? Again, social function is a very complex construct. So I wanted to understand if there are specific dimensions that are driving this effect. And is this effect moderated by OFC reactivity differently in men and women? So again, I use the Human Connectome Project, which is that publicly available data set. This time, I use a subsample of everybody who endorsed at least one symptom of DSM-4, alcohol abuse or dependence. This gave me a sample of 491, a little half of whom were female. And again, they're all around 30 years old, primarily white, very little ethnic diversity, and made around $50,000 a year. I use Hayes Process Macro Model 3 to test this relationship, which I'll show you in just a second. And as a reliability analysis or stability analysis, I employed 5,000 bootstrap permutations to generate 95% confidence intervals. And then finally, I conducted a sensitivity analysis using both the insula and dorsal anterior cingulate cortex. So these were the 2 moderated moderation models that I tested. So the 3-way interactions that I tested. The first one tests the effect of social relationship quality on drinks per drinking day, which was my measure of alcohol use, whether perceived stress affects that relationship and whether that differs by sex gender. And the second model B, I tested separately in men and women, whether the OFC moderates that relationship. The measure of social relationships that I used was the NIH toolbox of social relationships. It was actually a really nice toolbox because it parses down this very complex construct into 3 subdomains and 6 subscales. So it parses it to social support subdomain, which is further divided into emotional support and instrumental support. And I know you back there can't read that, but some examples are emotional support is I have someone who understands my problems, and instrumental support is someone who's around to make my meals if I'm unable to do so myself. So like transactional support. It parsed it into the companionship subdomain, so friendship subscale. For example, I get invited to go out and do things with other people versus the loneliness subscale. I feel alone and apart from others. And the social support subdomain, which is parsed into the perceived rejection subscale. For example, people don't listen when I ask for help versus the perceived hostility subscale. For example, people act in an angry way toward me. The measure of negative emotionality I used was the NIH perceived stress scale, which probes in the last month how kind of chaotic or uncontrollable folks feel that their life is. For example, in the last month, how often have you been upset because of something that happened unexpectedly? And the measure of OFC reactivity I used was specifically this angry, fearful faces task, which for those who may not be familiar is when you stick people in the scanner, really just ask them to look at these faces and match this bottom row to the top row to make sure they're paying attention, but it's really to gauge brain reactivity to these angry or fearful faces, kind of so these socio-emotional stimuli. And the control for that is the matching faces. And again, this is a region of interest analysis, so I only looked at the OFC, which was driven by that systematic review that I just showed you. This is a very broad analytic flow. So I first started by testing what I call global social relationship quality, which is the average of those 6 subscales, and whether that had an effect on drinks per drinking day differently in men and women. Then, given a significant effect here, I then tested each of these 3 subdomains, controlling for the other 2 subdomains to try to identify which of the subdomains was driving the effect. And for each of these significant subdomains, I then tested the pertinent subscales, controlling for all the other subscales. I then tested separately in men and women the OFC model, so whether the OFC moderated the effect. And for all these analyses, I controlled for age, race, ethnicity, income, of course, other relevant subdomains and subscales, and accounted for multiple comparisons. So this was the first analysis, so drinking by global social relationship quality, perceived stress, and sex gender. And I found interestingly, so I'll orient here. So women are on the left panel, men are on the right panel. X-axis is global social relationship quality, so the general social relationship quality. Y-axis is drinks per drinking day. And I found a significant effect that was driven by men, such that in men with average, and here's perceived stress, low perceived stress green, average in blue, red is high perceived stress. And I found a significant interaction such that in men with average to high stress, so blue, average and blue, high and red stress, higher global social relationship quality was actually associated with higher drinking levels. So the men who were sort of stressed to very stressed, the higher level of actually social relationship they endorsed, the more they endorsed drinking. I then tested each of those 3 subdomains, and I found that specifically companionships was driving this effect in an interesting way. So you actually found that in women, in the left panel here, women with low levels of companionship, those with higher stress in red drink more than those with lower stress, but we can see that this effect is actually mitigated in women with high levels of companionship. In contrast, in men with low levels of companionship, those with higher stress drink less than those with lower stress, but this effect was actually reversed at higher levels of companionship. So together, this suggests that companionship may be protective against the effect of high stress in women, but in this sample, companionship may actually exacerbate the effect of stress on drinking in men. I then tested the effect of the friendship subscale and found that the friendship subscale was driving this effect in the same exact pattern that I just showed you, such that friendships seem to be protective against the effect of high stress in women. We can see that the difference in drinking levels mitigated in women at high levels of friendship, but it may actually exacerbate the effect of drinking in the sample in men. And then finally, we also found an effect of loneliness that was driven by specifically in men with high stress, such that lower loneliness, so more connectedness, lower loneliness is associated with higher drinking in men. And finally, when I tested the role of the OFC in moderating this effect, we found that in men with high OFC reactivity to negative emotional faces and high stress, again, we found the same effect in loneliness, such that lower loneliness is associated with higher drinking. So in men with high OFC reactivity as well as high stress, we see this positive relationship between lower loneliness and higher drinking levels. When I conduct the sensitivity analysis, so also testing the insula or the dorsal anterior cingulate cortex, which are also brain regions that are implicated in salience detecting in substance use populations, I found no effect in either of these brain regions. So together, again, I know I just showed you a ton of three-way interactions. In summary, we found that in women, higher companionship and friendship was protective against the effect of high stress on drinking. And this is in line with that model of negative emotionality related drinking that I showed you before. In contrast, in men, we found that higher companionship or friendship actually promoted drinking. And again, this is in line with that level of positive reinforcement. With that model of positive reinforcement that I showed you before, it may primarily be driven by the subgroup of men with hypersensitivity to these negative socio-emotional stimuli. Importantly, this supports our previous finding that high social support buffers against the alcohol misuse in women. It also supports that I showed you in chapter 1. It also supports the finding from chapter 2 that the OFC may be a key neurobiological mechanism driving this effect. And importantly, supports again that negative and positive reinforcement model of drinking in women and men respectively. And again, this integrates those three key domains, social, psychological, and neurobiological factors in improving alcohol misuse.
There was a question in the chat, which is if this also apply, if you have any data on trans women and men, and what do you think if this would also apply?
Yeah, so we don't have any data on trans populations here. This was all self-reported binary, sex and gender. And I think that's actually a good, I'll come back to that at the end, but that does actually lead to more questions about the sex effects versus the gender effects that we were unable to capture in this study, and how we can best measure sex versus best measure gender and model them together in an interaction effect, which was not done here. Yeah.
I had a question on, do they break down at all, like the friendship versus companionship? Like who their friends and companions are? Because can women not be protected for men and then men be protected for women if there's like
Yeah. So this data that did not collect kind of the gender composition of the friend groups, but we do see in more broader sociological literature of of people in this age group and millennials that men and women in general, but particularly men, tend to report generally same-sex gender compositions, especially in kind of drinking behaviors. And then we see a very much protective effect, especially men of marriage, on reducing drinking levels. And as kind of levels of marriage have declined, there's been an increase kind of levels of alcohol misuse in men that seems to be related to that kind of declining marriage rate. So there is an effect of gender composition, but it seems like in this literature, at least, it seems that the gender composition tends to be more same-sex, and this is leading to alcohol use. Good question. All right, so that was a good time for questions, because now I'm switching gears a little bit. I just showed you 3 pieces of evidence about sex-gender differences and negative emotionality and reward-related alcohol misuse in adults. But I mentioned in chapter 1 that there's this continuity between adolescence and adult patterns of use. But we really don't know about childhood. So there's evidence about adolescence, about adulthood, but not very much evidence at all about childhood use patterns. So that led us to our 4th chapter, which is environmental health and psychological factors predicting alcohol sipping in childhood, a machine learning analysis of the ABCD study, which was recently accepted to the Journal of the American Academy of Child and Adolescent Psychiatry, and it was co-authored by Greg Nicholson in the lab. So here I'll be talking specifically about early alcohol sipping, which is generally defined as trying alcohol without taking a full drink by late childhood or early adolescence. So generally around ages 9 to 13. It is not uncommon. In the United States, it occurs in around 20 to 40% of kids, but it is associated with problematic alcohol use in later adolescence and adulthood. And it's important to understand early alcohol sipping because delaying initiation of use decreases the risk of adulthood alcohol use disorder. But alcohol sipping is very difficult to study because it has an extremely complex etiology. So there are environmental factors, for example, parental use and approval, as well as access to alcohol within the home. There are health factors, for example, poor sleep and early pubertal status, psychological factors like higher sensation seeking, and brain-related factors, such that there's some evidence for both functional and structural differences, predictors of age of initiation, although brain indices of sipping specifically rather than full alcohol use is less clear. More recently, machine learning approaches have been used to help kind of parse this very complex etiology and other substance use outcomes, which together inform the current study aim, which was one, to identify which domains, so environmental, health, or psychological, or brain, most accurately classify early alcohol sipping, and two, to then empirically identify specific factors that may be most predictive of early alcohol sipping across these domains. So to do this, we use the Adolescent Brain and Cognitive Development Study, the ABCD study. It's composed of almost 12,000 participants, ages 9 to 11 across the United States. And for this analysis, we only examined kids who endorse sipping with permission. So this means we excluded accidental, furtive, or sneaky sipping, kids who endorsed only religious sipping, and then kids with inconsistent age reporting. So that led us to a sample of 10,707 participants. Almost half of them were girls, and of those, 1,498 of them endorsed sipping by the baseline, so around ages 9 to 10. We then applied two different machine learning techniques to classify these sippers and rank their predictive factors by importance, so how important they were in pushing the model towards sipping. And then we ran a series of validation analyses, which I won't talk about here, but I'm happy to answer questions. So the first machine learning approach that we use is extreme gradient boosting, or XGBoost, which is a non-parametric decision tree ensemble method for classification and regression. What this means is that it identifies predictors of an outcome of interest. So for example, sippers here. And this is just one example of a basic decision tree that I made as a schema. So for example, we have this factor: can the child access alcohol within the home? Yes. Is the child permitted to drink at home? Yes. That kid is more likely to be classified as a kid who has endorsed sipping alcohol. In contrast, we have, can the child access alcohol in the home? No. Are there inconsistent alcohol rules? Well, yes. But is there low parental responsiveness? No. That kid is less likely to be classified as as a kid who has endorsed alcohol sipping. We use fivefold nested cross-validation to tune these hyperparameters and assess model performance that generate these decision trees. And what's important is that although these models are highly accurate, they're difficult to interpret. So if I want to know, is low parental responsiveness more important, or is high screen time more important? Is permission to drink more important in predicting alcohol sipping? It's difficult to know with these models. So in order to interpret those decision tree models, we then apply our second machine learning technique, which is called Shapley additive explanations, or SHAP, which computes the unique importance of each of these variables. So that means if you have a variable space of these four variables here, for example, access to home, screen time, alcohol rules, and parental response, SHAP identifies the relative contribution of each of these factors in predicting your outcome of interest. So in this case, sipping by ages 9 or 10. It then generates these SHAP plots, and this is just one example from a previously published paper about cannabis use levels, and it ranked each of those predictive factors by importance from top to bottom. So we can see that here, openness to experience was the top ranked factor in predicting higher cannabis use levels in this example. And it does so iteratively through all the variables that you are assessing. So we identified top predictors of both an environmental model, psychological model, and health model. We found that the environmental model was the most predictive model in predicting alcohol sipping. The next most predictive was the health model. And finally, the third most predictive was the psychological model, and interestingly, the brain-based model. So we used functional MRI, structural MRI, and resting state MRI, all performed significantly worse than all these phenotypic models. We then identified, for each of these models, we then identified these clusters of these kind of subclusters that are pushing the model towards early alcohol sipping by using these this plotting schema that shows you kind of the underlying correlation structure. So for example, things that are highly correlated to each other are plotted very close to each other. Things that are not highly correlated with each other plotted far away from each other. And we can see that there are these 5 underlying domains of environmental clusters encompassing parental responsiveness, parental somaticism, SES, maternal prenatal alcohol use, and family norms that push the model towards early alcohol sipping. And in the health model, we found that clusters probing physical activity, self-harm, prodromal psychosis, early pubertal onset, as well as sleep patterns push the model towards early alcohol sipping. And in the psychological model, factors probing sensation seeking, negative urgency, impulsivity, school competency, reward processing, and verbal IQ push the model towards early alcohol sipping. So I know that was a very broad overview, but I just want to make sure that we have time for the last paper. So in general, we found that environmental factors were the most highly predictive factors of early alcohol sipping. And within the environmental model, specifically access to alcohol was the most predictive factor. In addition, there were individual level health as well as psychological factors that were linked to sipping, although less so than the environmental factors. Interestingly, at least at this age, brain-based factors were the least useful in predicting early alcohol sipping. But what this study didn't address was how these factors interact together to result in early alcohol sipping, and of course, whether there are sex-gender differences and how they lead to alcohol sipping. So that leads me to my fifth and final chapter, which is sex-gender differences in a causal model of risk factors underlying early alcohol sipping in childhood, which is currently under review. So again, I showed you in chapters 1 through 3 that there's this pattern of negative emotionality and reward-driven alcohol misuse in women and men, respectively. In chapter 1, we see that these risk factors also exist in adolescence, but whether these sex-gender differences also present in childhood is less well established. So the current study aim was to examine the sex-gender differences in a causal map of early alcohol sipping. So again, I used the ABCD study. I used the same sample that I just showed you because this was a follow-up study, that chapter 4 study. And I identified top predictors from each of those clusters from the environmental, health, and psychological models that I then input into this causal discovery analysis. I only retain folks with complete data. So my final sample was 9,253 participants. And again, I input these 9 predictive factors into that causal discovery analysis approach, which I showed you in chapter 1, which was that machine learning approach to generating causal structures. And I did so separately in girls and boys. And then performed a stability analysis. So I just did this iteratively 100 times and retained only the reliable edges. So I'm only showing you the most stable causal structures here. So in order to identify which of the predictors I put into the causal discovery analysis, again, for each of these clusters, I identified the most predictive factor in each of these clusters. So for example, this is just a schema of its environmental factors. I generally identify the highest ranked predictor. So for example, in this family norms purple cluster, easy access to alcohol was the top ranked predictor in that cluster. So I input that into the CDA. Similar for this SES, high parental education was the most predictive factor, so I input that into the CDA. I did the same thing for the health factors. Generally, I took the top ranked factor, although I did retain both suicidal ideation and self-injurious behavior because of their clinical implications, and also adjusted some to reduce missiness. And again, for the psychological factors, I generally picked the highest ranked factor in each of those clusters and put those into the CDA. I then examined the causal structure in boys and girls separately. And this is the causal model of sipping in boys only. I know this is a little alarming to look at because there's a lot of edges to look at, but what I want to get across here is that there's a causal structure that's connecting these environmental in purple, health and salmon, and psychological in blue here. And what's important here are these actual edges that are leading to sipping that are shown in red. And we can see that these environmental factors in boys, specifically parental education, access to alcohol, and prenatal alcohol use, have this causal effect on sipping in boys. Interestingly, we also see a causal effect from sipping onto more disliking of school, so less liking of school, and higher sensation seeking in boys, these two edges here. When we compare this to girls, we see a very striking continuity in that these environmental factors are the same. So parental education, higher parental education, more drinking, higher prenatal alcohol use, and easier access to alcohol have a causal effect on sipping. But what's interesting is that girls only, we see this causal effect from suicidal ideation, passive suicidal ideation, onto sipping. And we do not see any causal effect onto anything else from sipping that we saw in boys. So I know that was very startling to look at. So this is a summary of the key findings. So in boys and girls, we see these environmental effects leading to early alcohol sipping. In boys only, we find this effect onto sensation seeking and disliking of school, while in girls only, we find this effect from suicidal ideation onto early alcohol sipping. So again, we find that in both boys and girls, environmental factors are important. In girls only, we find this role of passive suicidal ideation onto sipping, which is very much in line with that negative emotionality related drinking behavior that we see in adolescence and adulthood. In boys, we see that sipping alcohol caused higher sensation seeking and more disliking of school, which again is in line with that reward-related pattern of use. And again, this suggests that these patterns of negative emotionality and reward-related behavior are present even at this very early development stage at extremely low levels of alcohol use. So just sipping.
You might have said this earlier, sorry, but in terms of the sipping, is it just at one time? Could it be multiple? Could it be amounts? Is there any kind of weighting that way, or is it just any time ever?
So it was endorsed that have you sipped at all, any sipping at baseline. And we did examine how many kids then reported taking full drinks or kind of finishing the drink. And of those, it was very low. It was around 1 or 2%
There
reported.
wasn't like a frequency or anything like
Yeah,
that.
there was no.
Okay, thank you.
Yeah, so it was a binary, have you ever sipped? So again, bringing us back to this integrated model of alcohol misuse, we find that in terms of neurobiological factors, hyperreactivity, the OFC, to negative emotional faces seem to be particularly important for men in driving alcohol misuse. In terms of psychological factors, negative emotionality and stress in men and women are both important, but particularly important the role of negative affect in women. In terms of social factors, low social support seem to be particularly important in conferring risk for alcohol misuse in women, whereas high companionship or friendship seem to exacerbate the risk in men. And in terms of developmental, in the developmental space, we found that actually interesting limited utility of brain indices and predicting low-level experimental alcohol use in childhood. Whereas in contrast, we found in psychological factors that suicide ideation seemed to be important for girls, whereas sensation seeking and school competency were linked to alcohol misuse in boys. And then finally, in both boys and girls, access to alcohol, higher parental education, and more maternal prenatal alcohol use was important for conferring risk for alcohol sipping in both boys and girls. So together, I've integrated here this model of sex-gender differences of alcohol use, such that women in general tend to drink as a form of stress relief, so drinking to cope, and that those who do so at low levels of companionship or friendship or social support are at higher risk of alcohol misuse. In contrast, men and boys on average tend to drink as a form of social reward, and those who do so at higher levels of companion friendship seem to be at a higher risk of alcohol misuse, particularly in a subgroup of men with higher reactivity to the OFC to these negative socio-emotional cues. So with that, I will conclude and thank my funding over the past 4 years. A lot of funding from the NIH which will continue through the last 2 years of medical school, hopefully, as well as other internal funding. And of course, my lab and Anna for her guidance and everybody else in the lab and MSTP and the GPN.